happening, and a knowledge of the risk factors and everything is usually known to all of you. But what we really will be discussing today is the acute care and to some extent the rehabilitation. Remember that the continuum of stroke management starts from primary prevention of risk factors like hypertension, like preventable risk factors like hypertension, smoking, obesity, diabetes, and non-preventable like the gender distribution, the age predisposition, family history, genetics. So the alteration of the risk factor profile of a patient comes under the primary prevention. But once the stroke has occurred, what really starts is the entire crux of our discussion today, and that takes place not only in the emergency but also in outpatient departments, as we shall be seeing. So the management flow chart of stroke is basically talking about the diagnosis of stroke and to rule out mimics. And then once the stroke has been diagnosed, to classify it into the different types and then to find out the optimum method to manage it. And some of the common interventions are to either conservatively manage these cases or to do the so-called mechanical thrombectomy or thrombolysis, which is an ischemic, or control of blood pressure, which obviously is not thought to be a big thing, but we will see how much the stroke neurologists have dedicated their lives only for the management of blood pressure in a certain type of stroke. And then finally, we have the revascularization procedures followed by rehab measures. Now, the BFAST algorithm was actually developed to diagnose stroke in the pre-hospital area. It is not, it is known, it is, asked to you residents to know the components of BFAST. Originally, it was FAST. B and E were added later. But basically, its main intention is to alert the peripheral people, the emergency personnel in other countries, and primary caregivers in our country to be able to find out that the patient might have a stroke. What usually happens, the patient has, maybe there's a 60-year-old man who suddenly feels there is a weakness of one hand. He thinks it is not serious and then he just thinks, I'll sleep. Yeah, afim le lete hain, very common in this place. And so jate hain bhai. And they think that they wake up and all heaven will be smiling in front of them. Doesn't happen. So very important to know the warning signs, and this is to be communicated to all, not just you people, but also across your families and friends and communities in particular. So what are the components? So if a person starts to talk about a sudden onset, usually most of the symptoms are sudden onset. So a sudden onset loss of balance or impaired ability to walk, complaining of sudden onset blurred vision. Do not think that loss of vision is not a stroke. Optic neuritis hota hai. So many of the cases can have a ischemic optic neuropathy or a CRAO or a BRAO, that is a retinal artery occlusion, and that's actually a form of stroke for the eyes. Now, when the patient complains of a weakness of one part of the face or arms, or sudden onset slurring of speech, so-called, which has no neurological counterpart, basically the difficulty in speaking, and you have very less amount of time to call for ambulance immediately. These are the components of BFAST. This is a warning sign of stroke. Be aware yourself and tell your family and attendants and friends to recognize these signs and immediately rush the patient to a good hospital for further evaluation. Now, when the patient has come to you with the BFAST algorithm and is suspecting to be that of a stroke, then your role will kick in. And one of the most important feature here is to be able to differentiate it from the mimics. So Rosier score, which we are not using, but I feel that we should be using it more often in our emergency, is basically an algorithm to recognize stroke in the emergency. Now you need not, by heart or wrote the components to memory. Remember, some of these are very common, which you usually ask. So components of the FAST, that is weakness of face, arm or leg, disturbance in speech and vision. These are some of the acute onset signs. But in addition, you also ask for presence of any seizure-like activity or any loss of consciousness or syncope. If the answer is yes to any of these, stroke is very likely, and this usually helps you to differentiate from mimics. Now remember, when you have seizure or activity, it has been given a score of -1, but remember that sometimes Seizures can be the presenting feature of stroke. For example, in cardioembolic strokes, that is strokes coming from the problem from any dysfunction of the heart, or in case of hemorrhagic stroke, seizure can be a presenting feature of stroke. So this is important. Now, you also have an online tool for the Rosier. I'll suggest all of you to be kindly muted. My voice is echoing. Yeah. I think I'm still Sarthak?
Yes, ma'am. The voice is coming.
I have no idea why it's echoing. Am I audible?
Yes, ma'am. Audible, ma'am.
Maybe something was there from your end. Anyway, so this is one of the online tools that you can use in order to recognize, differentiate these. But even if you have a seizure as an onset tool, remember that even if it is scored as -1, so also is loss of consciousness does not always preclude a stroke. They can also occur within mimics, but yeah, they do give rise to the chances of it being a mimic. Now, supposedly you have signs of it, the immediate thing to do is to do a CT scan. And once we have, bleed is very evident because CT is highly sensitive for hemoglobin and its products. So it's immediately visible on the CT, non-contrast. Now, the ischemic stroke is the one which is non-visible, right? So sometimes we can have markers for stroke which we can immediately see. For example, in these three cases, for example, in these three cases, we can find out some hypodensities. We shall talk about it later. In each of these scans, maybe not so much in the first, we'll talk about that. But you can also see that all the three of these patients had some varying amount of deficits. Now, the first scan had NIHSS of 3, so hardly any deficit, and to the untrained eye, it may be a completely normal CT. That's accepted from your side. In NIHSS 8, you do find that there is some hypodensity in the left as compared to the right. And in NIHSS 6 also, you find some hypodensity. But when you have such doubts, in the CT itself, you are not able to point out, need to have a second look. Maybe there is something else in the CT that suggests. Look at the position of the eyes. You find there is a conjugate deviation of the eyes. So the first one, not so much. It's obvious also the patient severity is very less. But slightly more severe strokes, you find that the eyes are deviated conjugately to one side, left in the second, in the center one, and to the right in the third. So conjugate deviation of eyes is one very important clue to tell you when you are having doubts in the CT scan. Apart from that, you need to find out and know some of the important acute signs of ischemic stroke, which you can see on the CT. Remember that up to 60% of CTs can be normal, but then there are certain other conditions which you need to understand. One of the most common of them, which you need to recognize, is the hyperdense artery, basically caused due to an acute thrombus lodging inside a intracranial vessel, and it's called a hyperdense vessel sign. Now, this case which was seen in a patient 2 hours after the onset of right hemiparesis. Look at the cleft of the MCA. You can look at the white arrow pointing towards the presence of a hyperdense MCA on the left side. Now, this suggests the presence of a thrombus inside the lumen of the vessel. And this usually pertains to a higher stroke severity, but this is one of the acute signs of stroke. The next one that you have is the obscuration of the lentiform nucleus. Now, lentiform nucleus is nothing but it's a part of the globus pallidus putamen. Is together known as the lentiform nucleus, a part of the basal ganglia. So subcortical gray matter. When you have an obscuration of the lentiform nucleus, it is called a blurred basal ganglia sign. This is also one of the earliest and most frequently seen signs. I shall not be talking about anatomy. We have had the classes earlier, and this is mostly about management. So it's starting from diagnosis. So look at this case. If you can discern, so you have arrows on the right as compared to the left, you have slightly more amount of attenuation, that is obscuration of the posterior part of the lentiform nucleus, which you can see with the white arrow. As how do you compare it? How do you know? In absolute terms, you can get backward. Always compare it to the normal side. Okay, and sometimes when you do not you are not able to catch it, it's better to go to the console, the chief main console that you have, and then to alter the brightness and contrast ratios, that is known as windowing. So once you see that, then once you do the windowing properly, you'll be able to see the darkness more clearly. Anyways, this is one of the earliest signs of CT scan. Now, this is also another blurred basal ganglia, hardly visible. We don't expect you to be able to catch it, but if you do that, it's great. Also, similarly, the insular cortex, which is highly susceptible to ischemia, can also show a similar loss of the sign, which is called the, I think, the insular ribbons, and I think I've misplaced the slide. It will come slightly later. Now, once you have the earlier signs, or you have a management that you need to know is to find out the extent of the stroke or the severity of the stroke. And one of the most common things that we ask residents to do is to learn to use the aspects. Now, aspects is nothing but the territories that are involved in the CT scan. Now, two levels of territories are involved. So first territory is at the ganglion level. How do you know the ganglion level? Look at the second, in the top panel, look at the second and the third image. So in the third image, the central image, you can find out you have the thalamus, you have the caudate, and you can also make out the basal, the internal capsule and the lentiform nuclei. The lower panel talks about all those where you can't see so much of details. Okay, the ventricles are only present, the little ventricles, you can't see the septum pellucidum, you can't see the fourth ventricle or the cerebellum. So these are the higher cuts, जो नीचे वाले panel में है. So you have some cortical levels, that is some cortical numbers, you can see 4, M4, M5, M6. Now this refers to the cortical divisions of middle cerebral artery. Now most of these territories are for the entire circulation, right? So all of these territories are supplied by the middle cerebral artery. So M4, M5, M6 is the higher cut. Now when you go down in the top panel, you find some additional numbers like a C, a L, IC. So these are nothing but caudate, lentiform, and internal capsule. So C for caudate, L for lentiform, IC for internal capsule, and you have M1, M2, M3, which are the lower divisions of the cortical branches or terminal branches of middle cerebral artery. So 10 territories in total, M1 to M6. Okay. So then you have the caudate, lentiform, internal capsule, and the insula. So these 6 plus 4, 10 makes up the aspect. So wherever you find a dark or a hypodensity, you try to find out what is the area, and then you will be able to find out the aspects. I'll show you a small example. Now look at, so just go very coolly about this case. So you have two CT scans, right? On the left panel, it is slightly lower because you're able to see the cerebellum beginning, you can see the septum pellucidum, you can see the fall, and then you can also see the third ventricle. A lot of it is obscured because of the cerebral edema due to the infarct. But you can make out that M1, M2 is definitely hypodense. Okay. Now, when you talk about the other areas, what should have been the caudate is now obscured. What should have been the lentiform is now obscured. You have a L form there. Definitely the internal capsule is compressed and pressed medially, and the insula is completely gone. So we have caudate, lentiform, insula, internal capsule 4 plus M1 and M2 6, right? So 10 minus 6 is already 4. Okay. Now let's move 2 segments up. Between M4, M5 and M6, we see M4 and M5 affected. So we already had 4 niche se, and since M4, M5 are also affected, 4 minus 2, 2. So this patient has an aspect of 2, which means this patient has a very high risk of developing malignant. In fact, he or she has malignant cerebral edema, very worse prognosis, and these patients may evolve into a midline, which is shift is already there, which you can see, and this midline shift can be fatal if it is not treated. These patients should be taken up for surgery. What kind of surgery we'll talk about? You just remove the skull to decompress the brain. That is the only surgery you do. So in case you're thinking some major surgery occurs, it's major because it's got to do with the brain, but it is one of the lesser because we are not handling the brain parenchyma. We are only relieving the skull above to relieve the brain contents of the edema and the pressure building because of it, right? So when you have these as aspects, it's one of the most important signs to know the stroke severity. But sometimes patient can present you with very transient symptoms. 5-10 minutes ka symptom hua and everything is gone and CT scan is normal. This gives you this possibility of TIA, which some of you may think is not important. But remember, TIA is the warning sign, or it is the opportunity that is given to you to make a difference to the patient. And how you assess, so which are the concerns? Suppose it is a 20-year-old guy comes to you with complaints of maybe transient weakness of one side of the hand, which was there for 5 minutes, disappears, okay? And there is, say, a hypertensive 72-year-old male who's also maybe a diabetic, okay? And the patient has come to you with a 2-hour complaint of 4 to 5 episodes of weakness and it is going down. So now you need to evaluate the particular patient to find out who of these two will be fitting into the criteria for TIA. Let's talk about the young boy. So we have the ABCD2 score for that. Age more than 60, maybe the 20-year-old does not qualify there. Non-hypertensive, 0. Neurological deficit, there is no hemiparesis, there is no speech problem. Okay. Duration was only 10 minutes, so 0. Non-diabetic. So the score of the young boy is 0 in this case. Let's talk about the 72-year-old diabetic hypertensive who's having 5 episodes in last 1 hour. Age 72, more than 60, 1 point. Hypertensive, let's say the BP is more than 140, 1 point, right? Clinical deficit, no hemiparesis, but upper limb weakness is there. There is no speech problem, for example. So in this particular patient, you will have 1 point for speech problem without weakness. And you have 2 points for hemiparesis. The patient does not have hemiparesis, but when you evaluate, but maybe the patient has complained to you of some weakness which has been resolving. So the patient, you might consider giving him 2 points, but you hold it, okay? Now duration is 1 hour. So 1 point he gets, okay? And then you have diabetes, so he has 1 point. So even without the neurological deficit, he's scoring age, BP, duration and diabetes 4. So once you have high score greater than equal to 4, which means very high recurrence of stroke in this particular patient, even when the patient has no deficit to you when the patient is in emergency. So do not send the patient away giving ecospirin. Please evaluate. Ideally, the best line of modality here should be MRI with MR angio. But if you don't have that facility, do a CT angio immediately. TIA is completely emergency procedure. A 1 day or 2 day old smaller stroke has nothing much to do. Maybe आप उसको conservative manage करके बेच सकते हो. Talking realistically in terms of PGI, ideally they should not be sent anywhere. But at least a TIA patient completely fine with so many episodes, at least 50% of them will have a full-fledged stroke to you, stroke in them in 48 hours if you have not treated. Do a CT with a CT angio immediately. If MRI is available, do it. If no MRI, it is taking time. Whatever is available first, immediately do it. And remember, that is why when we were discussing ABCD2 and we are finding out that these are the conditions for assessing the severity of TIA, we also have similar determinants of stroke severity. So the final severity of the stroke that you might have has so many other factors. So it will depend upon what clinical sense you have in managing the patient, what agents you use, what side effects the patient has to those agents, what are the routes of administration through which you do, what is the presence of the vascular status inside the brain in terms of collaterals, what is the reserved tissue the patient has in terms of penumbra, okay, and what is the time most significant in which the patient is presented to you. So all of these factors are going to make a significant difference in the outcome of the patient and also the final stroke severity of the patient. Now I'll show you this very small example. We'll not discuss in detail. Now just see if you can make out with the DSA the complete. Is my cursor visible on the left? I'm using my cursor. Can you see me, Tafsir?
Visible, ma'am. Visible.
Okay, great. So this is a DSA film, okay? So need not think so much about it. Just remember that this is the ICA, which is dividing into the ACA and the MCA, right? So remember that the MCA here is completely cut off, right? Whatever you can make out of it, when you give the dye from here and you're taking the whole, uh, you know, the phase of vessels, you can see that the MCA does not go, normally it goes laterally and it divides. And then there is the ACOM and the anticirculation, which you can see once you have injected the dye, but you see that the lateral part is completely cut off. And that means that the patient has an MCA infarct. Now, when you talk about these patients where we have a multi-phase CT angio, right? In multi-phase, the first side also shows a cutoff in the CT angio. That is the first arrow, the white arrow with the CT angiography. But gradually in the venous phase and the late venous phase, there is a delayed percolation of the dye through the vessels and you tend to have. That is not important for us to discuss. You see the diffusion weighted scan for this particular patient. Look at the CT angio. I don't have a corresponding CT image, but it would probably be slightly attenuated, not to this extent. But when you see in DWI, you see a whole territory, almost one half of the territory of the MCA being affected up to the central sulcus. On the flare, however, you find out that the flare diffusion, the flare changes have diffusion changes have not been taken over by the flare, which means that the patient has got a diffusion flare mismatch, meaning the patient is in acute phase of stroke less than 4 hours. This patient was not treated. Day 7, look at the diffusion weighted image. So what has happened in the day 7 compared to the first DWI is that the at-risk tissue, because MC supplies the entire territory as you can see on the day 7 DWI. So the first day, the damage was only to a core area, which was immediately attacked with the MC being damaged. But on the 7th day, the entire territory, due to lack of treatment, got damaged. And finally, you would also find that on day 7, the deficit of the patient is going to be significantly higher than that of the presentation. So these are the cortical blood flow maps. This is not required for you. The first was a patient who had very poor collaterals, right? So same amount of diffusion deficit had a huge stroke in the first one. When we talk about the second patient, in this case, when you also show do the DSA, you also find that there is an MC cutoff. Do a CT angio almost the same side, but look at the difference in the CT between the CT angio between the first and the second patient. You have so many vessels which are seen in the leptomeningeal part of the brain in the second and third phase, the first and second phase, right? But it is not present in the first phase. Look at what has happened to the diffusion weighted imaging. The first time also there is a relatively smaller area of deficit as compared to the first case. On the 7th day, it is only that same area which has got affected. So look at, so what has happened? That the collaterals have actually taken over the compromised blood supply and they have restored the blood supply to the brain, thereby limiting the area of damage. So always remember that we need to select our patients based on the amount of salvageable tissue that they have and how we choose these patients for whatever intervention. Also for thrombolysis, also for mechanical thrombectomy, all results will be modified depending upon the patient status. When we thrombolize, we know the criteria for thrombolysis now is 4.5 hours. We all use the two agents, alteplase and tenecteplase. Now we know the 0.9 milligram per kg, the initial 10% dose given immediately as a bolus, remaining 90% of the dose to be given over a period of 1 hour for the alteplase group, and the total dose should not exceed 90 milligrams. In tenecteplase, it is 0.25 milligram per kg. We have several trials which have been done to find out the optimum dosage of tenecteplase. Now, when we give that, our major concern is we are worried that maybe हमने TPA दे दिया और patient को bleeding हो गया, because once bleeding has occurred, then it's like split milk, the patient will not improve, right? So the most common side effect for any kind of thrombolytic agent is that of bleeding. Now, remember that it is both the agents have almost similar risk, but tenecteplase being slightly longer acting has a higher percentage of bleeding as compared to alteplase. Apart from that, you have certain other conditions which are very classical or characteristic of each of the agents. Now for TPA or alteplase, it is orolingual angioedema. Okay, and sometimes also pulmonary edema. These two side effects are usually not seen to that extent, but you can find more of cardiac involvement in patients with tenecteplase. Whether it is incidental or attributable, we do not know, but we do have some evidence of cardiac conditions like like myocardial infarction or even reperfusion arrhythmias in patients with tenecteplase administration. So remember that the adverse effect of thrombolytic agents also will depend upon the patient profile. But the most important factor that determines the safety of thrombolysis in a patient is the time at which you start the thrombolysis. The earlier the better. So if the patient has come to you within 1 hour of stroke, do not wait for the patient to clock 3 hours and then give. Do it as fast as possible. Immediately inform your resident stroke nurse if they're on team so that they can take it up. If the patient has come between 3 and 4.5 hours, now the time for you is to think about how much of the place or the brain is already infarcted. If you have evident hypodensity on CT, wise idea not to go ahead with thrombolysis. But if there is large vessel obstruction, the patient can be safely taken in for mechanical. Why? Because once you have a dead tissue, when you administer the thrombolytic, the chance of bleeding is very high. So if you have presence of manifest hypodensity on the CT scan in a patient, suppose the patient comes to you and tells you that 1 hour mein mere ko stroke hua hai, and you see that the CT scan has a huge infarct, it can only mean one thing, two things in fact. It can mean two things. The first thing it can mean is that the patient is lying, because in 1 hour you cannot have a fully established stroke. Or the second possibility, if the patient is telling the truth, is that there was a past infarct on which probably there is now a second episode. Now that you cannot differentiate unless you do an MRI. So 1 hour, 2 hours, towards 3 hours, the infarct becomes more and more manifest. Within an hour, you will only have the hyperacute changes that we discussed, like obscuration of the lentiform nuclei, the insular ribbon sign, the loss of gray and white matter interface. Now, just like we discussed, the bleeding of due to thrombolysis depends upon all these conditions. So whether the time at which you administer the thrombolysis being the most common, and the amount of area of involvement of the stroke. It's a large stroke, you will have chances of bleeding to be more. If it's a very small stroke, thrombolysis is more or less safe. Second, if you have a lot of small white matter changes, you will have a higher chances of bleeding. But if you have a relatively good parenchyma, you are safe in doing it. Now, bleeding due to thrombolysis is also defined under two headings, that is hemorrhagic infarction and parenchymal hematoma. Just remember, these are two separate entities. Parenchymal hematoma is more serious than hemorrhagic infarction. Hemorrhagic infarction is usually small petechiae. Parenchymal hematoma is when you have a lot of blood, whether occupying less than 30% or more than 30%, with some amount of space occupying effect. Right? So, like we are talking about these conditions, so any of these, a longer peritoneal time, the most common cause, and then obviously rest of the causes that we discussed. Now, also if the patient has got uncontrolled blood pressure, uncontrolled blood sugar, has got a high hematocrit, or maybe the patient has got intrinsic inflammatory sort of a status inside the brain, or there is some evidence of breakdown of the blood-brain barrier which is present in the brain, or microbleeds. So these are all these conditions which act together. So don't blame yourself only or the neurology SR कि भैया आपने उसका bleeding करा दिया. It's not always so upfront. You have so many other latent causes which can. If the patient has small vessel disease, it's one of the most common contaminants to a good thrombolysis. The patient will bleed even despite you doing the thrombolysis in the best scenario possible. Now let's come to mechanical thrombectomy. Now, as per the guidelines, earlier it was up to 6 hours, and now guidelines did speak about 9 hours. When we were doing our residency, we used to be very happy when the patient came at around 11 hours. And then sometimes it did occur to us that, patient, despite being, coming to you at 9 or maybe 14 hours, was very well kept. But there was a large vessel occlusion, and a lot of us during our times used to give low molecular weight heparin to, kind of dissolve the clot. That time nobody dared to do mechanical thrombectomy beyond 9 hours. But now the evidence is screaming, and we have two huge trials which were done in 2017 and 18. No need to discuss, go into the details of it. Basically, what they did, they talked about delayed stroke presentations. Okay, so dawn was 24, agle din subah tak, so 24 hours, and diffuse was another, which was like a 16-hour onset. Both of them basically talked about long duration onset of strokes. But how do you select them for mechanical or bridging? That selection of cases was done on the basis of visualization of the deficit or the salvageable tissue. Now that was defined differently in terms of dawn and in diffuse trial. So this imaging mismatch, like we talked about the diffusion flare mismatch earlier, I know a lot of it is very difficult, but whatever you can understand. So basically, the core infarct tissue, whenever there is an infarct that occurs, so there is a core tissue, and then there is a, there is a salvageable tissue. But that salvageable tissue also has. So the whole batch goes for exams. There are 4 failures, but there are 30, 40 who are on the verge of failing. Happens to all of us. So these 30, 40, they are like, if the teacher is not passing all, at least वो 2 दिन को fail करा दे, the black sheep तो हम लोग तो निकल ही जाएंगे, right? So that salvageable tissue is always on the lookout to escape punishment. It's also the same in the brain. Okay, so basically, so that salvageable tissue estimation is used in these trials through radiology means, and it was found out that even when you go as far as 24 hours, you can have a very good result. If you look at the outcome measure, you can see that good response was seen in almost 50% of the cases as compared to 13%. And there's a term called the number needed to treat. Some of you might know it. It's very good at 2.8, right? So obviously, all of these always usually depend upon how early, even in 24 hours, if you are close to this lower range of time, you are going to have a better result. Finally, after you have done the thrombolysis, you have done the mechanical thrombectomy, it is very important to discharge the patient. But this is something that you need to inculcate. You need to find out the type of stroke that you have, right? So that is done by the classification of stroke under the TOAST classification as a subtype of stroke. So the TOAST classification was given by Adams in 1993. Adam and Victor जो book लिखे, and we know that there were some of these causes: the large artery atherosclerosis, cardiomyopathic stroke, small artery or the lacunar strokes, and there are so many other causes, some of which are determined or undetermined, or some of these causes are unclear, right? So this, so remember, for example, if you have a dissection, so dissection is not usually due to large artery atherosclerosis. That part of research is pending. Maybe in the future we can throw some more light on that. It's definitely not cardiomyopathic. It can be, for example, if it is occurring due to a patient who has syphilis. So even that case is not a case of acute. So that gets classified under the other cause. Many times during discharge of patients, it is not possible for us to find out the cause of stroke, but to whatever extent possible, it is wise to do basic, at least large artery, cardiomyopathic, small artery strokes. But there are some lacunae in this classification. Beyond the scope of today's discussion, it is important to just know that. Remember that when you talk about the clinical presentations, you can see about this article. It's a very nice article that was used, that was done, and you can all read up on it. Remember that when you talk about some particular clinical features, so clinical features can be same even in multiple types of stroke. For example, cortical or cerebellar dysfunction can be due to cardiomyopathic as well as large scale atherosclerosis. But Sometimes some of the manifestations can be seen in small artery occlusion or lacunar syndromes, but they may have an imaging correlate or they may not have an imaging correlate. So if you have clinical features of CT scan or clinical feature of stroke, but you're finding out a normal CT scan, in that condition, it can very well be a small artery occlusion or or a lacunar infarct. So usually seen in diabetics or hypertensive or long duration. Sometimes even the MRI does not pick up. The 3 tests, 1.5, forget. 7 Tesla mein aata hai, we don't have that. No need to have it. Also, 3 Tesla में भी catch करना मुश्किल होता है. So remember, a lot of the strokes has to be clinical diagnosis. So small artery occlusion or lacunar strokes can be missed by the best availability imaging modalities. Don't let that discourage you from writing ecosprin or the particular treatment for stroke if you are clinically confident of the patient having a stroke. So how do you become clinically confident? Look for conjugate eye deviation. Obviously, after the clinical evaluation, look at the NIHSS, which is the stroke severity. Always ask about the symptoms which have occurred. Look for conjugate eye deviation. Look for all the symptoms of FAST, which we talked about. Look for planters. Sometimes you feel that the patient is maybe hysterical or maybe malingering. That's a confusion that usually arises. Do the planters. If the planters are upgoing, then definitely something is odd. Okay, so whatever we have talked here, it's a busy slide, but very easy to understand. Whenever you have a suspected stroke, look at the mimics may be ruled out and then do the FAST test. This is a reiteration of what I've said. Once you have done the FAST, ideally it should be done from outside, but chalo, yahan pe kar liya. And then rule out mimics, use the Rosier scale. I will advise all of you to take it up. It will help you a lot. Once you have confirmed the stroke, then always find out the severity using the NIHSS. Now, the assessment for the immediate scanning is to be ideally done by a CT. In our setting, it is the CT scan, forget about the MRI. Once we have the imaging available, if the patient is fulfilling the criteria, then we go ahead for thrombolysis. If the patient is not fulfilling the criteria, look for large vessel occlusion. If the patient has large vessel occlusion, then we go for mechanical thrombectomy with or without bridging. We are not discussing that. And whatever has been done, after everything has been done, patient should ideally be admitted to the stroke unit. I apologize for its absence, but you are the stroke unit at least till now in the emergency of PGI. So it's basically talking about the stroke unit with specialist care, which includes a neurologist, that is a resident, obviously with the seniors, that includes people like us, and stroke nurses, and also the attendants. To whatever extent you can, this should be provided with rehab, with speech therapy, and with proper nutrition. So that basically constitutes a stroke bundle. So this is usually the algorithm for management of stroke. And once the patient has gone ahead, then the patient may be managed accordingly or taken up for rehab and other services. For TIA, like we were discussing, I shall probably be skipping it. It's almost the same. I shall be skipping it. So anyone who's probably ABCD2 score more than 4, assess immediately for stroke and always do an imaging. Okay, to whatever extent you can understand, immediately do the imaging means do a CT scan and do a CT angio. Ideal should be MRI. Now, if MRI does not show anything and the clinical symptoms have improved and there is no vessel occlusion, you give a loading. Some people believe in giving a loading dose of antiplatelets. Ideally, you should give dual antiplatelets. And you ask the patient to visit the neurologist within 1 week. If the ABCD is more than 4 or equal to 4, patient has to be admitted, irrespective of the vessel imaging. So, for example, what can happen is sometimes the vessel might not show any large vessel occlusion, but the vessel might be undergoing repeated episodes of spasm. So, does not mean that you need to have LVO, large vessel occlusion, to ideally admit the patient. हम लोग नहीं करते हैं यहाँ पे, but the patient should be admitted if he has all the risk factors, that is age, blood pressure, the duration, presence of diabetes, and the clinical features. So once the patient is to be admitted, then the imaging is to ideally go ahead, and then the basic medical management is to take place. You are very lucky if you have done the angio of the neck. Yes, angiogram should always have both intracranial and extracranial, although you usually do it, but do remember to do in TIA and all these kind of strokes which have a fluctuating onset. Important to do extracranial always in addition to the intracranial. It is the same amount of contrast and it is to be done in the same phase. So please don't write intracranial and leave it. Always write a habit of doing neck vessels and circular villus together. And sometimes we also do the arch of the aorta in some other people. But for you, extracranial and intracranial is to be done in all cases. Don't think कि आप कुछ बचा रहे हो, कुछ एहसान कर रहे हो on the manufacturer of the contrast by ordering only intracranial. You're not. Okay, so in the same phase, it can both be done. Now, once you do that, and you find out something in the carotids, the one time that you can find out a patient who is NIHS is 0 and who has come to you completely asymptomatic with the complaint of a TIA, but you find the carotid has a plaque or a floating thrombus or some amount of occlusion, you have done for the patient what no one else can. So that's the key to this management is diagnosis. The radiologist के लिए बहुत easy, they will only put a stent. But diagnosing these patients, keeping them when suspicion is absolutely got no field or anything to be advocated, and the usual management is to send them home. If you are doing it, this is the most probably one of the biggest examples of cases where you can do something in neurology and you can send the patient home completely healthy, giving at least 20 years of life to the patient. Okay. So make it a habit to image the neck vessels and intracranial vessels in one go. In all patients of TIA, CT and CT angio is a must. Ideal management is MRI with CT angio, but okay, whatever we can. Okay. Okay, so here again, so finally when we have, I was just trying to tell you some of these causes when you try to discharge these patients. But remember that despite all of these, all of the work that you have done, you might have some other conditions where you will not be able to determine the etiology. So these are cases where you have a negative evaluation or whatever you have done comes out to be normal or an incomplete evaluation. So remember, for this category 5, stroke of undetermined etiology, so where you have 2 or more causes, supposedly the patient is diabetic, the patient is hypertensive, and the patient has atrial fibrillation. Now the patient has a stroke. So where does this patient fall? It is a large artery stroke, correct? So one may to fall karta hi, but the patient also has cardioembolism because he could have had cardioembolism. It's AFib, so 2 bhi ho sakta hai. Lucky and forget it. Other determined, no. So 5 may undetermined. So 2 or more causes identified comes under undetermined for some reason. One of the reasons why toast is has its own issues. But then the patient belongs to 1, 2, and 5A. So in these conditions, the patient, it's best to label the patient as 5A and to write down the risk factors. Because the stroke could be due to any of the causes that we have done. We don't know, and maybe the stroke could be due to all of the causes combined. TOST does not cater to that. Try to give a discharge TOST classification to your patients. Learn it from your residents. Learn it from your senior. Whatever I'm telling you today, wherever you have an issue, goes without saying. You have to learn from your residents if they know, right? So make that a habit. Now coming to ischemic versus hemorrhagic stroke. So we always know that hemorrhagic stroke comes, and so for example, the patient doesn't, or maybe you are out of PJ tomorrow and you have a patient who comes to you with a sudden onset focal neurological deficit, which you presume to be a vascular origin, falls under the rubric of stroke. You don't know because you don't have a CT scan, right? So you have a possibility of it being ischemic because 85% of the cases are due to ischemic stroke, 15% are hypertensive. What are the conditions that will make you feel the patient has hemorrhagic stroke? Remember, the hemorrhagic strokes are always usually by the law of the book, are more severe for the corresponding ischemic strokes. Second, hemorrhagic stroke occurs in an instant. A lot of the ischemic strokes are known to progress or gradually progress over a period of time, right? Onset of headache, presence of vomiting, seizures, these are all more common in comparison to the ischemic hemorrhagic type. And then you have, depending upon the site of hemorrhagic stroke, you have multiple other clinical features. So you can have aphasia, you can have agnosia, you can have hemiparesis, you can have coma. Sometimes the patient can just have an imbalance of speech, imbalance during walking. Sometimes the person can have a sudden onset change in personality, or the patient may immediately go to sleep. Sometimes the attendants can give a complaint that the patient has gone to sleep. So site-specific clinical features are very important to know in this ICH. And always whenever you have, make it a habit to do the ICH score. So this is relatively easy, much easier as compared to NIHSS. NIHSS requires training, something that I didn't discuss at length today, but it's difficult to do. It involves almost a complete neurological examination. You should be a master of evaluating most of the deficits that you're doing. But ICH score is much more easier. NIHSS requires a certification which is available, which you can all do if you have the time. And your stroke nurses are all trained, and even the residents are trained when they see the cases. Now for ICH score, you don't have so much of issues. Remember that it's one of the most robust tools to prognosticate strokes. So you look for the presence of the stroke, of the bleed, the volume of the bleed, the location, apart from that, the age, the ICH, right? And depending upon whether it is more than 30 and less than 30, presence of interventricular extension with the radiologist can help you with whether it's a cerebellar or a brainstem bleed or a cortical stroke, the age of the patient and the GCS, you have the scores. Look at the scores 3 onwards. So up to 0, it's obviously 30-day mortality is 0. It rises rapidly in a U-shaped graph. For 1, it's 13%. In 2, it doubles to 26. From 2 to 3, it is more than thrice 72%. And then 4, it's 97, 5, 6, it's 100%. So a score of 5 and 6, 30-day mortality is going to be 100%. So much for volume, very simple. Maybe someday when we talk or you ask me, if you meet me somewhere, I can tell you that this is derived from the volume of a sphere. So ideally, very simple law of physics, but given as ABC by 2. That is, you have to talk about the longest diameters in each of the axes, X, Y, and Z. Z-axis diameter is calculated by the number of slice segments in which the bleed is said to be present. A simple calculation, you just multiply the 3 axes, divide by 2 to get the volume. It has you might have a 7 to 10% issue in the actual volume estimation, but it's a pretty robust way of finding out the volume of the bleed. When you do find the bleed, however, apart from the volume, very important to find out whether the bleed that you are presenting is expanding or it has expanded, because expanding bleed is a very crucial thing to be managed. And we have so many signs in neurology. Suppose blending. So if somebody is maybe learned to shade, you can see that this is a shadowing area, or the presence of black holes, or separate areas of hypodensities which are separated from a relative hypodense area. So we also have presence of fluid levels, or when, like, you're swirling your coffee which has got cream on top of it, and then you have a mixed picture. So all these are signs of an expanding hematoma. On angiogram, you see the dye leaking at a active site. So this is a post contrast image, which one of the relatively specific signs for expanding hematoma. And why it is important? Because hematoma expansion is extremely crucial for management. On CT, the diagnosis is easy, but on imaging, it's very difficult, because the total time of the degradation of hemoglobin is divided into 5 stages. And for these 5 stages, you have T1 and T2 images, which can be completely confusing. I even cannot remember. But it's given by the mnemonic I bleed, I die, bleed, die, bleed, bleed, die, die. Something like that. So B for bright and D for dark, and I is for isodens. If you can remember, good enough, but nobody usually asks. If they ask such questions, they're out to get you. So good way to know, but it's not essential. Now, when you find these bleeds and you do have these, remember the most important thing is to get them to the ICU. So stabilize them immediately. Find out whether the hematoma or the bleed is expanding or not by means of the CT scan. Don't go for a CT angio in all these cases, because so many of these patients are likely to have hypertension-induced nephropathy. Use unnecessary time spent in the performing the CT angio, which usually you are asked to do sometimes because it saves time for some other people. It is not at all in the guidelines. And diagnosis of an expanding hematoma is only of interest in some scenarios, but for most practical purposes, it is not required. So only CT scan in all cases, and angio only when you have atypical cases of bleed, or you're suspecting a venous thrombosis, or you're suspecting an aneurysmal bleed. So we will not discuss much about it. So firstly, you just do a stabilization of the patient, look at the ABC, give them a neuro ICU or an ICU bed, and look at the temperature and the sugar controls, and go ahead with the normal management. But the most important part for them is to control the blood pressure and to reverse coagulopathy if it is present. It's an alcoholic liver disease. A patient has taken an overdose of anticoagulants. So in these patients, very important to reduce the systolic blood pressure. We have had so many trials, we were talking about it just now, or we will need to reverse the anticoagulants. And neurosurgical evaluation in some cases where it is mandatory to remove, which is not happening, but I would like all of you to know, because only if you know will the awareness be transmitted. So any cerebellar hematoma more than 3 centimeters has to be evacuated. There is no place for conservative management for hematoma in the cerebellum more than 3 centimeters, equal to or more than. Now, don't, if you've taken a CT scan at 1 hour and it is 2 centimeters, please don't wait until it becomes 3 and then do it. It's life-threatening. Immediately the patient should be wheeled into the neurosurgery. If you have a supratentorial hematoma, that means there's a cortical bleed. I'll show the images, needs to be evacuated. Now, so most important are these two: BP control, reversal of coagulopathy, neurosurgical evaluation. We all ignore the blood pressure control, but you would be amazed to find out that so far we have had huge trials involving thousands of patients over 7 to 8 years in each trial, only to find out how important and how much the BP should be lowered. So it started way back in the 1970s, where it was initially thought that lowering blood pressure was actually harmful. But the first trial, actually, which was Interact 1, showed that there is no harm in reducing the blood pressure. Okay, and then gradually it was actually found out that reduction of blood pressure is beneficial for the bleed. And then how much to reduce? So finally, the Interact 2 established that reduction of blood pressure to less than 140 millimeters within 1 hour should be the best way, and rapid blood pressure lowering is safe up to 140 by 90 below. Less than that, around 110, 120, that's bad. So make it low and keep it low. So there are some, I think even Harrison till now says that there should be a graded reduction and all. So that is not as per the clinic. That was for the old evidence, but that has now been refuted. Now, if you see these pictures, so you look at the first panel in AB, look at this large supratentorial surface hematoma going to the cortex, okay? So it has been beautifully evacuated. So it's just an evacuation. You find the skull table intact, and the whole thing has been scooped out neatly by the neurosurgeon. And what do you think are the chances for this patient? It's absolutely marvelous recovery in this patient. Look at the second panel. So A, B, C, D, E, F, F, massive bleed. Okay, so much in axial, but coronal, it's literally full, filling the hole, and the entire part has been evacuated by this. So dramatic and miraculous results. And then you have a third example. Again, patient, some daring neurosurgeon has done it for a thalamic bleed, okay, which presented with IVH and even hydrocephalus, and how beautifully it has. So all of these procedures have the side effect which the neurosurgeons like to tell, कि surgery का ये है. But tell me the prognosis of the patient with the thalamic bleed if you do not take up something. Sometimes what the surgeons do is, if it is, now this is a a bleed which is there towards the cortex as well as which is decompressing into the ventricles. Sometimes have very deep-seated bleeds which cannot be evacuated by the neurosurgeon. What they do there is that to relieve the pressure, they do an EVD. So even an EVD is good enough to decompress the bleed as long as it lasts. But for example, in cerebellar hematoma, which is a posterior fossa bleed, if you don't evacuate, the pressure can be transmitted to nowhere and it will be uniformly fatal. So here, by a suboccipital craniotomy, you can evacuate the bleed and have great results. What is more problematic is anticoagulant induced bleeds. These are catastrophic. For one, normal bleeds expand maybe maximum up to 3 hours. They expand sometimes in books 6 hours. And by 24 hours, it's absolutely stopped. Anticoagulant induced bleeds can just go on fungating like anything. For example, the baseline CT huge bleed, you can usually find out so some of the imaging, like a variegated edge or a horizontal level can indicate an anticoagulant bleed. And once it has grown to such an extent, it can keep on happening. Now, this is a mouse model for a control and a bleed on warfarin. Just see that it continues to expand over a period of time as compared to the control, which is a normal bleed. So these are catastrophic and these need to be reversed. So what are the agents for reversal? No, we know that it is vitamin K and we immediately give 10 milligrams IV for any patient who has an anticoagulant induced bleed or who has hepatic disease, which may be interfering with the manufacture of clotting factors. But what is more useful is the prothrombin complex concentrate, which is now available in Chandigarh. It was not available earlier, I think around 20,000. So the dose depends on the manufacturer, but it's usually 15 to 50 milligrams per kg, and it has rapid onset of action. The problem with FFP is that it does not have all of the agents required for doing. It induces a huge amount of fluid overload. You need almost 10 FFPs or 8 FFPs to do it. So the additional intravascular load sometimes aggravates the bleeding size. And finally, it also has cross-matching and other concerns. So that is taken care of by the PCC. It's only a small bottle like that of albumin, and it has got a rapid onset of action. Sometimes, though, it can precipitate thromboembolism, but in this patient, obviously, life will be paramount, so that needs to be done. Now, so you have surgery, we had anticoagulation reversal, and we have certain agents, like, for example, dabigatran has now a daratumumab, and then you have andexanet alpha, you have siraparantag, so many of these agents which are specific for the selective newer oral anticoagulants. But to be very honest, it needs to be given within a specific period of time. And sometimes, like I know patients who were given a daratumumab when the dabigatran used was that of a local or a biosimilar. It didn't really work. So for all practical purposes, you are lucky if the patient is a bleed with warfarin or or maybe acetrom. The first thing that you need to do is to load them up with try to normalize the INR and immediately ship them up for surgery. Try to reverse the bleed only is feasible when the patient presents to you within minutes, or maybe on table dabigatran has been given and the patient has bled, and then you try to reverse it. Otherwise, it is usually practically not possible. You can use it to control the extent of further deterioration, but I won't be really able to tell you the on-table realities. Finally, the post-stroke rehab. So once everything has been done, and you think that you have done the thrombolysis or the evacuation or the decompression, whatever. No, stroke management does not stop at that. So remember that now, once the damage has occurred, to limit the damage is also extremely important. And for that reason, we probably have the largest amount of investment of research in some countries has now been diverted towards post-stroke rehab. So we have certain therapies on which you might be asked questions. One of them is mirror therapy and constraint induced movement therapy. So what are these two? So the rest of it is brain stimulation with TMS, then robotics, virtual reality, tele rehab, you can know that. But mirror therapy and constraint induced movement therapy are basically based on, so constraint induced movement therapy is actually not new. In the earlier days when a patient had stroke, the normal limb was usually bound. It was even done in the Romans, and the patient was asked to fend for himself. So the patient would then grovel on the ground, and then the hemiparetic limb would start using itself because it was free. So the only way the patient could get something done was if they moved. So that's that subconscious signal to the brain to initiate activity in the paretic limb because of constraint of the normal functioning limb. And the same thing is used in mirror therapy when the brain is confused. That in place of the hemiparetic limb, a mirror is placed and the person receives an image of the normal limb. And the brain gets confused that this is nothing but my normal limb and it's not my disease limb. And then the improvement has been dramatic. So these are some of the agents which have been used for post-stroke rehab. And we also have a lot of growth factors which are being thought about. Now, there are some agents which you can find like citicoline and piracetam and some other molecules. Now, they have not been proven to be effective in any of the post-stroke rehab conditions. So there is no evidence to use it. Although you might be pharmacologically lured by some people, unless and until there is evidence, I will request you not to use them. Remember that recovery occurs way beyond rehabilitation has stopped. So that is because the neurological reversal of diseased neurons occurs to a considerable extent, right? So finally, these are the important points I only touched upon because management of stroke is just not possible in 1 hour. So learn to identify the stroke and always assess the severity of the stroke. Now, finally, do the best modality of management. Talk and discuss with your friends and your seniors to find out what needs to be done at that point of time. Don't waste time. Monitor the intervention that you have given because you can sometimes have side effects as and when limit the damage and include rehab. Most importantly, educate the attendants and caregivers so that they know the best way to manage the stroke patients next time it occurs. Okay, I'll take your questions. Anything you can ask. I hope it was to some extent understandable. Any questions?
Ma'am, one question, ma'am.
Yeah.
How does the management of wake-up stroke differs from stroke we know the time about?
Okay, so wait. So you know the two trials that I showed, the dawn and the diffuse trial, right? So wake up was actually included. Some of the wake up strokes were actually included in these groups. Now, wake up means what? So the patient has come to you. जब से मैं उठा तब से मेरे को ये हो रहा है. You need to ask two questions. Now, when the patient says I woke up at 3 o'clock, don't believe, okay? Because कौन 3 बजे उठता है? I mean, you know, you only have some realized souls, but not all. So do ask, did you wake up to go to the loo or, you know, to maybe drink water? And were you able to perform that activity without any deficits? Extremely important. If the patient says कि हाँ पहले तो मना करे, पहले तो बोलेगा कि ऐसे ही मैं कर दिया, मतलब when I woke up I had a stroke. But when you ask the question, he will tell you कि भैया मैं बाथरूम गया था, बाथरूम में ब्रश किया, वापस आया, बेड पे बैठा था, बेड के सोच रहा था, and then I had. So that's not a wake up stroke. That's an early morning stroke. So that's when, if that has happened at 3 a.m. and the patient has come to you at 8 a.m., you take the time of onset of stroke at 3 a.m. On the other hand, when the patient tells you कि मेरा जब से मेरा नींद खुला और तब से मैं देखी और मैं बिस्तर पे थी कि मेरा काम नहीं कर रहा था और मैं खड़े होने के लिए गई and then I fell down, that means the patient had stroke when the patient woke up, right? And then you don't take that time at 3 a.m. उसमें आप कैलकुलेट करते हो रात को कब सोने गए थे. अगर वो रात को 10 बजे गया था वो और 5 होगा. Okay, so in this particular, so very important to distinguish between the two. I'll tell you when we were residents, हम लोग भी ये कहते हैं हाँ wake up हो गया ना हाँ ठीक है last thing normal 10 o'clock beyond thrombolysis. अब तो वो concept ही नहीं है. अब तो कुछ भी है आपने कराना है perfusion. Okay, so whatever be the case, so wake up, no wake up, small stroke, you have to assess the salvageable tissue and then decide upon the modality. LVO, take off for mechanical thrombectomy, and no LVO, think about thrombolysis if there is a salvageable tissue. So I think over a period of time, you know, all these wake up, non-wake up, blah, 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 will be relegated into, you know, historical entities. And we should be talking about just in terms of the salvageable tissue of the brain. But for now, this is the way you do it. So 3 a.m., no deficit, but onset 5 minutes after waking up or 1 minute after waking up. Then the on time to be taken Last seen normal is 3 a.m. But patient wakes up and in the bed finds deficit. Last seen normal is when the patient went to sleep. Okay. Ask whatever doubts you have. You cannot learn it in a class. You have to take it case by case.
What is the management if the patient is already on anticoagulation, let's say for a reason of atrial fibrillation, and he has a ischemic stroke? So does
Exactly.
the size of the area of stroke depends whether we should stop it, when we should again restart it? What are the things needed to be considered at that point of time?
Okay, so 2 or 3 controversial entities I had left out. This is one of them. Now the patient is on anticoagulants and develops a stroke. Now, usually you ask about the INR. When did they do it? Were they doing it regularly? If the patient is a bleed, you obviously know that the INR has been through the roof, right? Now, if the patient has an ischemic stroke, whatever the patient tells you makes no logic, na? Because obviously it means that the INR has been subtherapeutic. But you don't have the INR value. Okay, but you don't have the INR value. And then you have 2 scenarios. You have time beyond thrombolysis, nothing to do except for sending the INR. But the patient has come to you acutely, 1 hour RHT patient on acetrom, which you usually find out. Number 1, reasonable certainty you can have that the patient has subtherapeutic INR. Ideally, the method should be you send for INR, and those hospitals that actually mention this algorithm have INR monitors, just like you have your glucometers. And वहीं पर INR estimate होता है less than 1.7, go ahead with thrombolysis. Now, suppose you have sent for the INR and it's not available, जो हमारे यहाँ पे होता है, right? So, you can take an educated guess, and even we have done, but you obviously have to be scared. आपको एक चीज उनके फैमिली को बताना होगा कि भाई in all suspicion he has a subtherapeutic INR, but INR आते आते the time for thrombolysis will go. I can still feel that if he is in the golden period and the evidence, the infarct is not evident, I can thrombolize. Okay, and in this case, obviously thrombolizing will not have an adverse effect, because thrombolysis, contrary to what you think, is only for a short duration. Now TPA is only present for 20 minutes, and tenecteplase is present for maximum 45 minutes to 1.2 hours, right? And then it goes from the body. So best will be send immediately INR and convince the family to thrombolize. And better than that scenario will be if the patient has large vessel occlusion. Usually they have a LVO. Why, I will tell you. So usually what happens is that it's a cardiomyopathic stroke and a massive clot has formed in the heart. And that thing goes and it lodges somewhere in the LVO. So these are scenarios for mechanical thrombectomy. Mechanical thrombectomy may you give only a small dose of heparin. So supposedly the patient has LVO. Wheel in the patient for mechanical, and you can obviate or you can exclude thrombolysis, और आपको वो रिस्क नहीं लेना पड़ेगा अगर, क्योंकि वो रियल वर्ल्ड सिनेरियो की मैं बात कर रही हूँ. अगर आपके पास है भाई मीटर, तो आप INR करो, 1.7 से कम है तो thrombolysis करो. I must have thrombolized 4 or 5 patients without the INR report. None of my patients have bled. Again, 2 reasons. RHT के पेशेंट्स के वेसल्स बढ़िया होते हैं, उनका हार्ट कमजोर होता है, they have no atherosclerosis, the brain parenchyma is 100% normal. The chance for thrombolizing these patients, the adverse effect profile for these patients for developing TPA induced bleed is negligible, except for only one, when the stroke is massive. बहुत बड़ा टेरिटरी में स्ट्रोक हो चुका है, ब्लड ब्रेन बैरियर लीकी है, थ्रोम्बोलाइज करोगे ब्लीड होगा. बट पर से 1 घंटे के अंदर पेशेंट आया है, नॉन अफोर्डिंग है, INR नहीं है, चलेगा, इतना खराब नहीं होता है सिचुएशन. बट लार्ज वेसल ऑक्लूजन है, यहाँ से डायसेक्शन पड़ा है कि take them off for mechanical thrombectomy and completely get rid of. एक तो mechanical thrombectomy के लिए जब आप लेते हो आपका window भी बढ़ जाता है, right? So you can take it up for a longer period of time, and then you don't need to give TPA because that risk will now be managed by thrombectomy. Okay, are you clear?
Yes, ma'am. Ma'am, when should we restart warfarin if the patient has undergone a surgical?
Okay, again an important question. So okay, so I'll yeah, one more thing before I forget. So TPA in stroke mimics. Now again, for the same reason, supposedly there is a patient who's there as a stroke and you felt and then you thrombolized. Okay, some of us also, our residents also do, we also did, our future generation will also do. So they said कि आपने इस पर TPA waste कर दिया, so costly medicine, और उसके bleed हो जाता तो. Now evidence says that there is no risk of TPA induced bleeding. Why? Because again, stroke mimics of stroke, likely for example seizure, or maybe say somebody had a headache, okay, or a syncope. Again, the brain parenchyma is normal. TPA will cause damage in patient where the blood-brain barrier is leaky. Now, blood-brain barrier is leaky due to what? Either you have pre-existing microbleeds, or the patient has all these risk factors like age, diabetes, hypertension, or it's a large stroke which has already been onset. But in a stroke mimic, the parenchyma is again normal. The blood-brain barrier is intact. So the side effect profile for TPA to cause damage is no. तो आप ये बताओ भाई, एविडेंस नहीं है मिमिक्स में थ्रोम्बोलिसिस करने का कि वो डैमेज करता है, कि वो ज्यादा ब्लीड करता है, राइट? बट डेफिनेटली पैसे का खर्च हो रहा है तो वो आप देख लो, right? So that's why, but we usually, that's because we have a cost factor attached to TP here. In many government hospitals, TP is now given for free, and hopefully we'll have it here also. Now the second condition, when we restart DVT prophylaxis and when we restart anticoagulants. Now in a patient with cardioembolic stroke, the recommendations are 14 days as per the paper. But to be very honest, if a patient has AFib and the stroke is not of a significant extent, you have gone beyond the period of mechanical of decompression. Suppose you're thinking there's a large stroke and the patient needed a decompression hemicraniectomy. अगर वो risk आपका चला गया है, stroke settle होने लगा है, ischemic stroke, आप start कर सकते हो. Cardioembolic strokes sometimes have a lot of hemorrhagic component. Once the hemorrhagic component has fully resolved, that usually takes 7 days to 14 days. That is the reason why 14 days has been given. So once the hemorrhagic component of the stroke has completely resolved, you can start. Patient with bleed who had AFib. Now, usme the diagnosis is critical. Some people say wait up till 3 weeks. Some people say wait for more. Restarting antiplatelets, restarting anticoagulants post-bleed is extremely controversial. But in a patient who has AFib and has developed a bleed, if it is due to anticoagulant-induced bleed, sometimes the whole criteria, not exactly criteria, but as per studies, even 9 weeks have been talked about. But in those patients also, till the last bleed has been visible, has been completely eliminated by repeat X-ray, आप नहीं start करते. Antiplatelets you can start if the patient, for example, has CAD and the patient had a bleed. आप उसमें once the bleed has started to fully resolve, there is no mass effect, clinical improvement has been substantial, you can start, but go slow. DVT prophylaxis, however, you can give low dose heparin in these patients, single dose, but initial 24 hours में कुछ नहीं देना है. Okay.
Ma'am, regarding thrombolysis in a patient who is already on DOACs, ma'am, suppose a patient has taken today's DOAC dose and has presented with us with a massive infarct within the window period, how to judge whether we have to thrombolyze the patient or not when patient is on DOACs?
Yeah, so you see, so there, you have depending upon different kinds of drugs, okay? So a lot of people also recommend reversing because here the best treatment for, the best evaluation for them will be the measurement of the PTT, which is an index of action of the NOAC. Prothrombin time तो नहीं है, PTT है या PT है, prothrombin time है, okay? और partial thromboplastin time है, तो उसके ऊपर से आप बेस करके निकाल सकते हो. Supposedly the PTT is elevated. Now we don't have that test being done here. Supposedly you get it done from somewhere and it is elevated more than 2 times normal, you revert. Okay. Now for dabigatran, which has a relatively longer duration of action, many of the people actually recommend a reversal of dabigatran using idarucizumab and then thrombolyze. Okay, now that's the way it goes. But to be very honest, thinking for any of these patients, so any of these patients who's developed a stroke when on NOAC or for anticoagulant or like traditional anticoagulants, the best option for them is mechanical thrombectomy if there is evidence of LBU. Now, a lot of these people also say that if the patient has got some anticoagulated blood running in the body and the patient has had a smaller ischemic stroke, just reclining and improving the pressure head, if you can't thrombolize the patient, has sometimes been found to lyse the. Usually these patients will be seen by you in CCUs, right? So either you revert, because we have no way of finding out the PT. That unfortunately is the problem. But guidelines will ask you to revert it first and then go for thrombolysis. Again, you don't have time, but इसमें best है अगर आपको LVO मिलता है आप mechanical के लिए direct भेजो and completely obviate thrombolysis. Then there are also cases about bridging. Okay, I have not talked about bridging. Now, bridging basically means that while the patient is being taken up for mechanical thrombectomy, you give a running dose of thrombolysis. Now, it has usually been found to be superior, and the effects are found to be comparable. Actually, see whether you thrombolize, whether you do mechanical, सब कुछ depend करता है. Time is brain. Okay, so that adage needs to be remembered. So the earlier you thrombolize a patient, the earlier you take up a mechanical thrombectomy, the patient profile's improvement is going to be better in that order, right? So when these conditions have been, when the studies have been done, when they have been talking about bridging and doing, तो इसका मतलब है कि आप bridging को करवाने के लिए भी you are allowing for some amount of time. So whatever bridging you are doing to save the brain, that much amount of neurons you are damaging just by the by the passage of time by doing no intervention. So these trials are actually, I feel, counterintuitive, because they are trying to tackle the problem by creating another. So in any case, it has not been found to be harmful. So mechanical thrombectomy with or without bridging basically is probably not much different. Okay, so ideal scenario talks about doing bridging, because sometimes what happens कि आपने mechanical thrombectomy plan किया और patient का cannula गया और but हो नहीं पाया. Sometimes now this is complicated, but there occurs distal migration of clot. आपने यहाँ से किया, वो clot वहां से lyse हो गया, इतना friable clot है. And there are so many things known about clot subtypes also. Now supposedly this is a very friable clot, very soft clot. तो उसमें क्या होता है, फिब्रिन कम होता है and cells होते हैं, वो छोटा 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 हो गया. The moment you put the stent, it will lyse and it migrates distally. So you have a shower of smaller strokes distributed in the entire area. Reperfusion थोड़ा सा होता है, but उसके साथ सारे dislodge कर जाते हैं. उसको तो आप stent से नहीं निकाल पाओगे. That will be taken care of by the bridging part. Okay, so no harm in doing it, but some may, you have to be cautious whether thrombolysis or mechanical. If the aspects is poor, if the stroke is already clearly evident to you on a CT scan, you are not going to derive benefit. In these cases, you need to do the perfusion. Find out the perfusion deficit, do the perfusion study. Significant perfusion deficit, go ahead with the thrombolysis, go ahead with the mechanical, whatever. Okay. Or
Thank you, ma'am.
All of you people, cerebellar hematoma में न्यूरोसर्जरी वाला बोल देता है, I mean no names, but और न्यूरोलॉजी वाला बोल देता है कि एंजियो कराओ, टेल नो इंडिकेशन. ओके, सीटी एंजियो करा के स्पॉट साइन देखने के लिए कोई बोलता है, बोलो नो, इट्स अ रिसर्च एप्लीकेशन. Whether the patient needs surgery or not, so basically in the evidence, so now that you have been asking, I will tell you a little bit about it. देखो what they decided, so they will tell you, one of these people will tell you कि भाई evidence नहीं है कि benefit होता है, जो 2 trials है stitch 1 stitch 2 करके आपको बताएंगे. हुआ क्या, they decided to do evacuation in bleeds in some number of patients. Now देखो आप एक सेंटर में कुछ करते, मैं बोलूंगी मैं पीजीआई में कुछ अपना 100 पेशेंट्स में करके और उसको पब्लिश करूंगी and I will ask the world to follow as a talker. You need to have a multi-center trial, each center agreeing to do it with these stipulated guidelines and having neurosurgeons or doctors of equal caliber. It is extremely difficult, okay, to fashion or design these trials. Whatever, when they decided to evacuate, find out the role of evacuation in these trials in hypertensive ICH. We know cerebellar evacuate, clearly known. Surface bleeds matlab 1 centimeter less than the cortical area, इवैक्यूएट, क्योंकि आपने बस थोड़ा सा ट्यूब डाल के इवैक्यूएट करना, उसको स्कूप कहते हैं. सो यू स्कूप आउट इजीली विद लिटरली लाइक अ स्पून एंड यू डैमेज लेस टेरिटरी. अगर एक डीप सीटेड ब्रेन के अंदर पड़ा है ब्लीड, आपको वहां तक जाने में यू आर डैमेजिंग सो मच ऑफ नॉर्मल टिश्यू. दैट इज देयर कंटेंशन कि आप बीजी ब्लीड में तो कुछ भी करके निकाल दो, आप इतना कॉर्टेक्स इंटरनल कैप्सूल भी पेनिट्रेट कभी कभी कर लेते हो. व्हेन यू आर डूइंग द बेसल गैंग्लिया एंड कमिंग आउट द इंटरनल कैप्सूल इज आल्सो डैमेज्ड and even the insula is damaged, तो क्या फायदा? That's what they say. Now what happened is when these people designed this for evacuation of non-surface bleeds, and there was one group for medical intervention and there was one group for surgical intervention. करने तो आए थे कि वही करेंगे. 28% of the patients on the medical group deteriorated. 28% मतलब 1/3. और वो सारे 28% को उन्होंने सर्जरी करवाया. मतलब कि डॉक्टर बायस्ड है towards doing surgery. Obviously आप भी होगे कि अगर मेडिकली वर्सन कर रहा है तो कुछ भी सही, अटेंडेंट्स विल टेल यू कि ऑपरेट कराओ, वी आर रेडी फॉर एवरीथिंग. बट बिकॉज आपका इंटेंशन टू ट्रीट अप्रूव्ड एनालिसिस है, आप वही बताओगे कि उसमें बेनिफिट नहीं हुआ, तो फिर क्या हुआ? क्रॉसओवर हुआ था ना. 28% अगर क्रॉसओवर हो रहा है आपका मेडिकल मैनेजमेंट से सर्जिकल में, इट जस्ट शोज दैट योर ट्रायल इज अ फेलियर. And stitch 3 is not possible because stitch 2 had 400 bleeds taking all over. Easy to think, but it doesn't happen because you require huge infrastructure and money to do this, and people are probably just not ready to carry it out. So telling कि आप एंजियो करा लो, उसके बाद में करूंगा, M6 है अब मैं नहीं करेंगे, नहीं, ऐसा नहीं होता है. ब्लीड है, आइडियली अगर सरफेस ब्लीड है, करना है. सेरेब्रल तो करना ही न्यूरोलॉजिस्ट से पहले न्यूरोसर्जरी के पास होता है. दैट्स द वे आई हैव लर्नड इट. ओके, दीस ब्लीड्स कम टू मी फॉर फॉलो अप. They never came to me in emergency, they always went to the neurosurgeon. But anyway, so but you have deep-seated bleeds within 2 hours, 3 hours, young patient, immediate, you will have great results with surgery. And surgery means evacuation, not decompression. उसमें decompression का क्या चक्कर है? Because it's a deep-seated bleed. Edema तो हुआ ही नहीं. Okay, so don't wait for a longer period of time for the patient to go from M6 to M5 to M4, M1. वो नहीं होता है, तुरंत करना है. Okay, any more questions?
Ma'am, one thing like how sensitive is ABCD2 square for ruling out a TIA? Suppose if a patient of around 50s with a Asian profile of obese patient comes to us with a localization which is not included in hemiparesis or speech deficit, and that improves, and we consider
Right.
diagnosis of TIA. Should we start at piston or antiplatelet?
No, so like I said, see, ABCD2 is just a screening, so which means it has to be sensitive but not specific, right? So obviously, like I was giving you this example, उस patient में क्या था कि आपका एक elderly बंदा था जिसको neurological deficits थे नहीं, but by virtue of his age, his blood pressure, his diabetes, and his duration, he was fitting the bill. Which goes on to say that elderly people are more likely to suffer from TIAs than younger patients who are coming to you with similar deficit. Maybe usko bas seizure hi hua ho. But still, you can't be sure 100%. The best way for them to do is to do a MRI diffusion weighted and a T2 flare. So अगर उसमें आपको MRI में diffusion restriction दिखता है, it's not a TIA, it's a stroke. अगर diffusion restriction नहीं दिखता है, ये stroke mimic भी हो सकता है. अगर diffusion restriction दिखता है तो भी stroke mimic हो सकता है, because in epilepsy sometimes you have basically that particular area has kind of is excitable or maybe as depressed, and you have a regional area of hypoperfusion, but diffusion restriction तक नहीं पहुंचेगा. Although isolated cases have been reported, we also have published for stroke mimics and chameleons. So you can the best way is that at least you are not letting go of the vulnerable population. आप एक 20 साल के लड़के को TIA का क्या चांस है, unless उसको मोया हो या preceding history हो. So in these cases what else you can do? Obviously आप अगर आप टकाइस ऐसे कुछ सोच रहे हो तो भी उसमें पेशेंट को हाइपरटेंशन रहेगा, पल्सलेसनेस रहेगा, बट एटलीस्ट आप एक एल्डरली पर्सन को नहीं जाने दे रहे हो जिसको वही सिम्टम्स है. younger person can escape and probably you will miss something there, but you are very less likely to miss a TIA in a young patient than an old one, which is why the ABCD2 has been so designed, keeping in mind the cardiovascular risk factors which increase the chances of a TIA as compared to that for a younger individual. This is not a very specific test. The most specific is clinical evaluation plus MRI, diffusion weighted and T2 flare. So also for mimics, lot of cervical spondylitic will come. मेरे हाथ में दर्द हो रहा है, भाई उसमें NIHSS evaluate करो. NIHSS I skip because बहुत ज्यादा स्लाइड्स हो रहे थे, बट NIHSS आपने evaluate किया 1 year 2 है. NIHSS में तो वो नहीं है, पेन हो रहा होगा बट ड्रिप नहीं है, पूरा उठा लेगा. Okay, and is doing everything else. Look for the planters, and if a patient is feigning, look for conjugate gaze deviation. Malingering patients may conjugate gaze deviation of eyes, and malingering means severe now. In that degree of severity, you will have conjugate gaze deviation. Look for conjugate gaze deviation. Look for planters. Always, always, always rule out sugar hypo and hyperglycemia. Okay. Last year, I was taking a round in emergency at Holby में. So there was this man who was bound by, by some of you people, just a learning experience, and was shouting. कुछ इधर उधर बोल रहा था. Okay, so the first day I took a round and I went. तो मैंने पूछा ये क्या हो गया इसको? So somebody said it's alcohol withdrawal. So I went, ठीक है चलो चले गए. Day 2 I went. The patient was, you can say, the patient was जो मतलब fluently he was talking in English, and he was a Tamil or something. So I just stopped, and again my resident said कि no ये neurological नहीं है मैम, psychiatric है. So I was like चलो पूछ लेते हैं because I'm interested. And then suddenly when I asked the history, it was found out that he had a sudden onset this thing, and he was still pending evaluation for psychiatry, by the way, second day maybe. Non-alcoholic tha. And he was a Tamil fellow who was involved in something that I don't remember exactly, something that required some stamping, mapping of these letters. And he had left the job and then done a lot of other odd chores. And then suddenly he had a sudden onset this.